Yeah, I'm going to ask Paul O'Brien and Laurie Sachs to join me. I'm going to let you do your introductions to put a little context around why the two of you are talking about management of side effects. It's a great segue. We've had early stage information, later stage information, and now Laurie and Paul are going to share some information with you about managing those side effects that Dr. Potvin was talking about. Laurie is a pharmacist, and Paul is a RN, and I'm really pleased to say that Paul was the recipient of our Kidney Cancer Canada Nurses Award last year for excellence in kidney cancer nursing in honor of our founder, Tony Clark. So he's very near and dear to our heart, and we appreciate the help that he's providing us tonight. So I'll turn it over to you two.
I'm one of the pharmacists here at the Cancer Center, and I've been here almost 20 years. And when I first started here, there was nothing for kidney cancer. So it's really been exciting to be involved in, as Kylie said, all these clinical trials that have ended up with numerous drug options now. It keeps me really busy, both trying to, there's kind of the costs, I'm looking at it from two different ways, the side effects and then the funding. In the pharmacy, we have a lot to do with helping people access these medicines. We spend a goodly portion of our day doing that. So I'm glad to say we're making headway, but there's still room to grow. So I'm just going to briefly touch on the side effects because I think Dr. Potvin's done that, and I know that Paul has a great presentation going through more details about how to deal with the side effects. So some of the drugs, the individual drugs, have kind of their own side effect profile that is kind of unique to them. The hypertension was something that we really found we need to kind of keep an eye on. It's not like your regular hypertension where your blood pressure goes up and you kind of watch and wait. You need to act on it right away. So the hypothyroidism, so we will monitor the thyroid levels and, again, act on it. It's something that probably will need to be supplemented for while you're on your therapy and potentially for afterwards. And then cardiac concerns with Sutent. There are some cardiac events, so if you've got a cardiac history, then we'll kind of look and see whether that's the best medicine for you. Everolimus, this is our next to, like the second line therapy, our first go-to there. It has, as Kylie said, some pneumonitis, so we really have to watch out for any signs of a lung infection and kind of do a chest x-ray and see what rule out infection versus is it the everolimus that's causing the problems. And then hyperglycemia and hyperlipidemia. So again, they'll monitor your blood sugars, we're going to monitor the cholesterol and lipids and act on it if we need to. This is my first time using the Prezi, so I really didn't want those boxes like that, but I couldn't figure out how to fix it. So this is what we got. Pazopanib, we sometimes see some more hand-foot syndrome with it versus the other ones, and then we really have to monitor liver function tests with the pazopanib because that's one of the side effects that we have to dose reduce for and monitor. It's not something you can do anything about, it's just your body, how it reacts to the medicine. And axitinib. So again, this one is very similar to the sunitinib, so high blood pressure, the hand-foot syndrome, and again, the thyroid abnormalities. So those are all things we're going to monitor because management of these things, so treating adverse events early and proactively is essential to maintain our patient compliance, to make sure you're still able to take the medicine, and optimize your outcomes and your quality of life. Because if we make you feel horrible, that's not the goal. We want to make you feel as best as you can while we're still trying to control the disease. And that's a quote from Dr. Rivaux in Bordeaux. So the other side of things is funding, and that's kind of where I have a lot to do with our patients. So currently in the first line setting, when I talk about EAP eligible, this is government funding I'm talking about. So in order to have government funding, you need to be over 65, perhaps on Trillium, on disability, or on home care. So you have to have a government-funded drug plan in order for these EAPs that we talk about, which is a letter that we do to the government on individual patients. You need both parts of that pie. So if you're 43 years old and you're far away from being 65, we need to work with you to develop other plans. And I know that this is one of Deb's real go-getters, kind of, we want to have access, if this was, as she's saying, if it was an IV medicine, Cancer Care Ontario funds a lot of IV medicines. Because it's a pill and you're taking it home, then it's your responsibility for payment. So we really do work a lot with we're trying to push the government to fund these medicines and across the board. In different provinces, that's true. In BC, I think they have a BC Cancer Agency, and it doesn't matter if it's a pill you're getting or if it's an IV medicine you're getting, it's funded. So we really need to kind of, I think that's one of the, there's going to be a launch in the spring, kind of trying to put this forward and make it in the government's eyesight and front and forward. So it is funded right now in intermediate and favorable risk as a first-line therapy. Pazopanib is also funded in a first line if you can't tolerate the suitant. So you have to try the suitant. If you can't tolerate it, then you can, and you haven't progressed, that's you can't progress, you have to be tolerating, you can't tolerate it. Then you can switch over to pazopanib. But again, you have to write another letter to the government saying why you need to do that. And apparently you have to have clear cell for that, because we got a rejection letter back today saying, or not a rejection letter, saying a letter requesting more information. So they put the criteria out there. Sometimes it's a bit of a game getting the right criteria down and the information the way they want it. Temsirolimus, as Kylie mentioned, there's that intermediate, favorable, and poor risk. Cancer Care Ontario pays, this is an IV medicine, so again, it doesn't matter, as long as you've got an OHIN number, you're going to get the temsirolimus if you're in that poor prognosis risk factor. So that's the only place it's funded. And we don't tend to see a lot of temsirolimus, which is good because we don't have a lot of, hopefully then, poor risk patients. We've got catching things early and more intermediate and favorable risk patients. Second line. So as Kylie mentioned, everolimus is usually our next step. It is AAP eligible after you've progressed on sunitinib therapy. Axitinib and pazopanib are two other medicines that are out there. And right now there is no government funding for either one of those medicines in the second-line setting. A lot of private drug plans may potentially cover them, and there are access programs. GSK has an access program for pazopanib to help with copays, and the axitinib they can look into copay assistance and drug coverage, but there is currently no government-funded option for those two drugs. And I guess the other thing I would choose, as Kylie said, clinical trials. That's how we've gotten kind of where we are, and I think it's really important. And I've had people go through about 7 lines of therapy. They've gone on a study before we had Sutent, then they go on the Sutent, then they go on the everolimus, then they go on axitinib, and then they go on another IV, the PD-1 inhibitor, and then I think there's something else. That some of them, these guys, and the great thing is, that's years. So this is, as Kylie said, it's a chronic disease now. It's not a death sentence. So that's my plug for clinical trials too. And that's so. Thanks.
So I always like starting conversations with old quotes, and my favorite thing about those old quotes that they're usually true. Even if we can't prevent side effects, I've found that early intervention certainly can make a difference in the amount of treatment we have to give to get somebody back to baseline. Oh, it's going to be really messy here. Give me a second here. So, unfortunately, side effects, if left untreated, by their very own, will not spontaneously just go away. So much like these dominoes that will fall, unless we do something about it, we can't get the patient back to where they were. So some sort of either active intervention or stop in the medication. So with Sutent, for example, we see a gradual buildup in side effects and toxicities over the time they're on, whether it be 2 weeks on or 4 weeks on. And during the off weeks, then those patients' side effects get better. Or we can intervene with an intervention that, again, will bring the patient back to their baseline. So it's been said throughout that stopping or delaying treatment is problematic. So we know that the occurrence of adverse events can cause treatment interruptions. So patients aren't getting the therapy as prescribed. Doctors sometimes have no choice but to dose reduce. And we know that if you feel really lousy, you're less likely to get up in the morning and take that pill. Targeted therapies are considered cytostatic as opposed to cytotoxic. Our standard chemotherapies we use kill off the cancer cells as they try to divide. And to actually get the disease control we want, we have to maintain a therapeutic level of that drug in that patient. So I'm going to talk to you about some specific side effects. And hopefully you won't be too offended by any of the pictures I show, but certainly diarrhea is something that can turn you on your head. Now, first thing we often do, we'll kind of rule out the obvious, the things that are caused by infection, so things like C. difficile, for example. We already have good therapies for them. We can get you back online. We can also modify your diet. We can look at things that stimulate your GI tract, right? So if we drink a lot of coffee, that may have a problem, and I'll mention a few others. Motility inhibitors, drugs like Imodium or Lomotil, slow the bowel down, less speed in the bowel, less output. And then, of course, the importance of hydration drinking, because if you're dehydrated, you're going to have problems with that, and you're going to feel other problems such as fatigue, weakness. There are foods that certainly can contribute to this, and there are a number of diet books over there you might want to look at. These are just a few suggestions. Many of these suggestions you have to customize, unfortunately, through a trial and error to see what works for you. We can give you general guidelines that will be helpful, but each individual is different. And some people find this approach more beneficial than that approach. So certainly removing skin, seeds, and membranes might be helpful, or eating smaller meals more frequently, and avoiding foods that produce a lot of gas might be problematic for a certain number of people. As I mentioned earlier, things that speed up the GI tract, beverages that contain caffeine or chocolate will be problematic. People who have lactose issues will have problems with milk products. High-fat foods can also be problematic. And for some patients, even reducing the fiber in your diet might be a temporary fix for those situations. This was mentioned a little bit, this syndrome called hand-foot syndrome, where the palms of the hands and the feet get red and very sore whenever pressure is applied. This is a picture of a patient of ours. Unfortunately, it was more of like a callus. Ignore the date, that actually isn't correct. And this patient was unable really to walk because it was just too painful. So again, there are things that we can do to reduce the intensity of this, if not make your life a lot better. So limiting exposure to hot water or temperature, really. And that's not only there, but down below you'll see that when you're doing dishes, perhaps the use of rubber gloves actually keeps the heat in and makes that situation worse. Avoiding activities that cause unnecessary force or friction. So obviously hard running or jogging, aerobics, long walks might be problematic when you have this, as well as common things like using a knife to cut things or screwdrivers to turn in where you have to do a lot of pressure. Rashes, again, was mentioned. There are a variety of things we can do for rashes. They tend to be in a photodistributed, meaning areas that are exposed to sun. They can be folliculitis, facial flushing, macular papular, or eczema-like. And we do, again, have treatments. Early treatments easier and better than waiting until it's a real problem and then perhaps having to have a dose reduction. So prophylactic treatment may include lotions. We do actually have a triad that we use here, avoiding hot showers or hot water on hands and alcohol-based products. So a lot of lotions out there actually have alcohol as a drying agent, and you want to avoid that because it's an irritant. Mouth sores, again, another very common thing with a lot of our medications. And of course, that's going to impede your oral intake and lead to other problems. It can be on the tongue or on the gum. Prevention, again, key thing here to good oral hygiene, appropriate diet. Reducing the contributory factors, avoiding of certain foods. Acidic food might actually make it worse. Protecting the mucous membrane, so when it does occur, we actually have medications like Mucogesic that will help you. And then, again, just like with diarrhea, make sure it's not an infection cause. So things like thrush. A few more pictures. Obvious things like denture problems. We need to make sure your dentures, what thrush might look like. So if you have white patches in your mouth, we need to know that if you're talking to the nurse over the phone, because that helps guide us in what type of treatment we might use. Ulcers are also something that's important to know. Certain foods are easier to take and tolerate when you have mouth sores than others. And this is a brief list. There are others, and again, individuals may find differences, that they may find those foods that we suggest you try not very helpful, and foods that we didn't think they could get down tolerable. taste change. So this is, again, another challenge for us because a lot of our therapies actually cause taste change. And if food doesn't have much appeal, if it loses its taste, then you won't eat it. Again, depriving yourself of the nutritional value that your body needs. So we need to experiment. Everybody has their own taste. Some people like spicy food, some people don't. Some people like foods that are saucy, some don't. It's really up to you to try and find the foods that best fit your situation, and especially if you're complicated by also having a coexisting mouth sore. Foods and fluids that require less chewing are usually better tolerated than foods that you have to chew more extensively. Brushing your teeth and tongue often, actually pre-meals, will make the foods taste better and may allow you to eat more. If foods taste metallic, you may try, again, several different things. There may be temperature variations that you find better, whereas marinating, again, the use of marinades may vary if you have mouth sores. Plastic utensils or chopsticks may be better than using stainless steel. And some protein foods such as milk, cheeses, yogurt, custards, and puddings are better tolerated than, say, a meat, for example. If the food is overly sweet, you may want to dilute it or maybe add a pinch of salt to decrease the sweetness. Conversely, if it's too salty, low salt, or add a little bit of sugar to sweeten it up a bit to make it more appetizing. Bland foods, we can add in flavor enhancers, different spices, condiments such as barbecue sauce, mustard, ketchup, or herbs and seasonings, again, to add more flavor to the food, to make it, again, more desirable or more likely for you to eat. So this is actually pretty much how patients describe themselves. They just don't have enough to do anything. And so for our patients, it's really difficult for them to want to stay on a drug when they feel they have no real quality of life because they spend their whole time in bed. So we need to rule out, again, secondary causes that we can readily treat, like anemia. So if your hemoglobin's low, we can do something about that. Thyroid disorders, we can give you medications to correct those. Exercise and energy conservations are things that you can do to put some control back in your life. So exercise, again, varies. It's not an easy thing to do, and I certainly don't make it sound like it's a walk in the park, although it could be. So again, different times of day might be something you want to try to find the right thing for you. Exercising with somebody, again, avoiding the initial desire to go over and above what you're really able to do. So often we start on these endeavors and we got great ideas that, yes, I'm going to go to the gym every day and I'm going to lift this much weight, and then you kind of feel a little sore, and the next day, well, maybe not. And that's followed by another few days, maybe not. And eventually you stop going to the gym. So you have to stay within your limit and pace yourself. Drinking plenty of water, making sure you stay hydrated. So if you're dehydrated, you're actually going to be more fatigued. Just a short walk each day can help. Build on your successes. Increase your distance and monitor your progress. Bring a friend. Share the experience. It's more likely if you work together in a group than if you do it by yourself. And a pedometer is a way of actually recording the distances. Keep a diary. Again, celebrate your successes. Reward yourself for what you've accomplished. So energy conservation is something we could all do, probably. And really it's about thinking ahead. Try to pre-plan. Try to make your life as easy as possible. And when you are fatigued, this is really a big difference. So you may have to have chairs at various locations in your house. So it may not seem obvious to have a chair in the hallway, but if that's where you find you're often tired, sitting down for a minute may give you a break that you need. When you're coming out of the bath, having a chair there to help you sit down, put your clothes on there, drying off, or having a toweling dressing gown would be a really neat thing. It basically dries you. You just stand up inside it. I often actually get up in the the morning, and I have everything laid out in the morning because I tend to not give myself a lot of extra time to get to work. So essentially I go from room into the shower, into clothes, through the kitchen, grab coffee, and out the door. Because everything is all set up in sequence to grab along the way. My lunch, my coffee, and thankfully, hopefully the car keys in my coat, unless I've forgotten them. So these are things that you can, again, pre-plan to make your life easier, reduce your energy output, and conserve what energy you do have. And again, some more suggestions of things that you can do. Better if you could get someone else to do some of your cleaning, or help you with meals, etc. Asking for friends, family, etc. that may be able to contribute and reduce your energy outputs. So that being said, target therapies certainly have improved kidney cancer, and it has changed the landscape. It's kind of late for me to introduce my experience with cancer, but I have to go way back to 1990 or so with a Dr. Wilson Mertens. And Dr. Mertens actually was treating patients on a clinical trial on the inpatient service using a low-dose interleukin-2. And that's where I first got my experience with kidney cancer. But I've seen tremendous changes from those days to where we're at today. So it's great that we have these new therapies, but these drugs are really only effective if we all give you them and you take them as prescribed. Because if we have to interrupt the doses, if we have to reduce them, or if you decide because you're feeling so lousy that you don't want to take it, we probably won't get the outcomes that we really want. So if we can treat these adverse events early, proactively, then we'll be able to maintain the benefits these drugs are capable of producing. And with that, that's the end of my talk.